Hi Kevin, how are you? Great to see you. Oh, you're a beautiful boy. What a guy. Hey. So I'm on Facebook Live, Kevin, so obviously you won't be able to see that, and everybody on Facebook won't be able to see me on Instagram. So what I'm asking is, for the guys on Facebook, if you have an Instagram account, come on to Instagram. It'll be better because you can see Kevin and you'll be able to see him clearly. And he's a beautiful boy, and you'll all really like to see him. He's got a lovely smile and he's got a great Scouse accent. So, quick update. Everybody that's sent me their email address, I have sent you two chapters in the sort of ebook, full arch ebook that I am constructing. So that has been sent. There's about, I think about 70 or 80 people emailed me. The first two chapters have gone out. I'd love to hear your feedback, guys. So they've gone out. If you've not given me your email address, then I've obviously not been able to get out to you. If you'd like a copy of my first chapter, looks at the 5 keys to treatment planning in full arch. And the second chapter looks at graft versus graftless sort of treatment planning for full arch. If you'd like those and subsequent chapters, then please leave your email address either on Facebook or on Instagram, and I will add you to the mailing list. The second thing I want to say is there will be a link that I put up on Facebook and on Instagram after this. Next Thursday, I'm doing a Zoom call. And on this Zoom call, I am going to talk you through from A to Z how I plan my full arch cases on a CBCT. I've had numerous people contacting me, asking me how I do it, how I've learnt. I've been fortunate, I've learnt from my mentors, and I'm going to share that with you next Thursday on a Zoom call for an hour and a half. I'm going to make sure by the end of it, you can plan full arch cases on a scan. And I need you really, I'm not able to do it in this sort of a format through Instagram or from Facebook. But if we can get on a Zoom call, then that would be great. So I will put up the link for that afterwards. And then you need to sign up, and then you'll get details of the Zoom call, which is next Thursday, 8 o'clock. So I've got some viewers. Just let Facebook guys. So I'm on Instagram live with Kevin today. So if you have Instagram, that's probably the best platform to engage, because I've got two mobile phones looking at me, and I'm not going to be able to you won't get eye contact through Facebook, but you will be able to see my eyes and contact through Instagram. So really on Instagram, guys, I've got Kevin here. He is a CDT, but first of all, he is a dear friend of mine, and I am so grateful for Kevin taking out time during this busy time of lockdown. We're in week 3. I know you've been busy. Listen, I was thinking about this. We're locked down by the government, and we've been locked down by our wives and our partners, and I know you've been busy painting. It's tough times. It's tough times. We've been locked down. Yeah. So, obviously, there's 3 things that we're going to discuss today, and we'll go on to them. And we're going to just really discuss what is it that I send to you as my technician, and what is it that you need from me as a clinician to get us started in our full arch cases. Number 1. Number 2, we're going to look at some complications that can happen. Thankfully, far and few between in our cases, but what kind of complications do we encounter in full arch cases? And that's in the interim prosthesis. And then thirdly, we're going to focus on what kind of issues can arise in the definitive prosthesis. So important to remember, our discussion today is based around the FP3 prosthesis and the construction of an interim prosthesis that's all acrylic. Really important. So FP3 prosthesis, interim is all acrylic, and my definitive, the most commonly constructed definitive, is a hybrid. So it's a metal bar with an acrylic wrap. So I'm not going to be talking about the other materials. I'm just going to be focusing on what I have the greatest experience of. Great. Kevin, introduce yourself. Let people know who you are, please. All right. Just 2 seconds. Guys on Facebook, I'm not looking at you directly because I'm on Instagram live with Kevin, my number one, my dear friend. Number two, my technician that I work really, really closely with. So I apologize, you won't see my eyes. I'm on Instagram. If you can go onto Instagram, that would be great. Also, hit us with some questions. Me and Kevin would love to answer your questions. You know, yeah, send them in. But Kevin's just going to introduce himself. So Kevin, tell us a little bit about you and how we met and your background.
So we met through a mutual friend.
Let's say say his name. We can say his name.
George. George. Yeah, we met through George. So we've been probably working together for about 3 or 4 years now. And I've been doing your work ever since. I'm a clinical dental technician. I've probably been in the trade now for 23, 24 years, so I've seen my fair share of full arch cases. I'm also a clinical dental technician, so I work a few practices up and down the northwest. But yeah, my main bulk of work is FP3 bridges.
Awesome. And where are you based?
Based in Formby, which is just outside Liverpool.
Right. And what's the lab called that you work at?
It's Ultimate Dental Lab in Formby.
Great. I've just moved my...
So full service lab.
Okay, great. Right, before we start talking about what we want to talk about today, I just want to give a bit of background why I thought this would be, you know, a unique but different format, and why I really wanted to do it. I had the pleasure of listening to Finlay Sutton the other day. I'm a partner. We've got 6 practices based up in Scotland, and Finlay Sutton, phenomenal prosthodontist, kindly offered to do a webinar for us. And apart from talking us through denture work, which is, I mean, his work is another level, there were 2 things that stood out for me during that webinar. One, his relationship with his technician. I can't tell you the number of times Finlay mentioned his technician, to the point where I know his technician's name. His technician is called Rohan. Okay, it's a bit similar to my name, Farhan, but Rohan is his name. And he reiterated the importance of teamwork and communication. And I echo that, because I couldn't do what I do day in, day out and deliver the work that I want to deliver to my patients without team support. And that's not only teamwork in the practice setting, but my CDT, Kevin. So that was the first thing. The second thing that I took away that I can also relate to when Finlay spoke was mentorship. Over and over again, and I've had the privilege of listening to Finlay speak in the past, he mentions his mentor, John Besford. And that's what I want to say. I have mentors. I've been mentored. I am still mentored for cases. And it's essential for me to be able to grow and develop as a clinician. Okay, so I just, and that's where this has come from. I wanted to change things a little bit and have a sort of discussion between me and Kevin about the things that go through our head when we treatment plan our full arch cases. So guys, I'm on Facebook and I'm on Instagram. Kevin, you can only see Kevin on Instagram. So if you can, move over from Facebook to Instagram and you'll get to see this guy. And he's got a lovely smile and a great Scouse accent. So it'll be great. Come and see Kevin. If there are any questions, please ask. No problem. I just want to remind you, also, I've sent out 2 chapters from my sort of ebook where I've collated the first 2 Facebook Live series. They've gone out. If you'd like a copy, I need your email. Second, I'm doing a Zoom call next week. I've had a lot of people come to me, ask me, how is it that you plan your full arch cases? And it's hard for me to do that here in this format. So I'm doing a Zoom call next Thursday evening, and I'll put up a link for you to join that. Okay, so further ado, the 3 things we're going to talk about, Kevin. What I give you, what you need from me to plan a full arch case. Number 2, some of the potential problems that can arise from your interim prosthesis. And finally, the definitive prosthesis and potential problems. So let's start off on, Kevin, when I do a full arch case, I send you upper and lower imps. I send you a bite reg. I make sure you know the midline that I plan for the construction. And I send you I send you a record of the interpapillary line. But there's something something really, really important that people miss out planning full arch. I tell Kevin my planned alveoplasty. Kevin, why is that so important?
That planning the alveoplasty is really important. That gives me a measurement so I can transfer that onto my model to give you a prosthesis or an interim prosthesis that's going to be thick enough and that you're going to be able to convert that confidently on the day and have that, have that bulk of the acrylic basically, and have that intaglio surface, concave, just to give you basically what exactly that you need on the day of surgery. Yeah. Alveoplasty is really, really important to portray for your technicians. We communicate on a daily basis, and this is why it's so good working with you as well, because the communication for me is key for a good end result right the way through. And we communicate from day one. As soon as you've got that patient in the chair and you're taking photographs, you're communicating all that to me, which is, it makes my job a lot easier and gives you and the patient ultimately what we're trying to achieve.
Yeah, awesome. Yeah, so let me just go over that again. What I send Kevin for these surgeries is I send him upper lower imps, I send him a bite reg, I record the midline, I record the interpapillary line, and I tell Kevin my planned alveoplasty. That is so, so important. Please do not just send work to your technician and expect them to then get you something back that you know that's appropriate. It won't be. You need to give your tech that information. Now, a couple of things. I work in multiple clinics around the UK. Either I'm working treating my own patients or I'm mentoring other dentists. Kevin's not with me. Even on day of surgery for a conversion, Kevin is not there. I do my conversions for the interim prosthesis on my own without Kevin. I'd love to have Kevin follow me around the country, but I can't afford him just to be there with me all time. So I do it myself. So the reason I say that, it's so, so important to get that stage 1 right, that communication between yourself and the technician, and they need to know exactly what you plan to do for the surgery. Because when I get that prosthesis back, I get 2 dentures back from Kevin. One I use as a guide, and the second I will then adapt. The second one I use to convert. Now, that prosthesis I get for conversion, it needs to be thick enough for strength and thick enough that over the next 3 to 4 months, while that patient wears it and I'm then be able to fabricate the definitive, it's going to sort of stand, go through function and, mastication, etc., and not break down or fracture, because that's critical.
I think certainly another note for Han is that these impressions that you send us for the interim prosthesis, they've got to be good impressions. We need all the anatomy on these impressions. We need adequate, buccal and labial depth. We need a good impression of the palate. Because don't forget, when we're making these interim prostheses, we need all these anatomical features to be able to give you something that's going to work. We need that buccal and labial depth to be able to perform the alveoplasty on the model. We need a good impression of the palate if you're doing an upper retromolar pads on the lower, to give us those landmarks so you can have stability from your restorative guides as well. So it's important that you give us good impressions,
Okay, perfect. Yeah. So another thing I should mention in terms of communication, we're in a day and age, we're really fortunate. Look, I'm on Facebook Live, I'm on Instagram Live here. Kevin's just on Instagram Live with me. But we've got such easy access to this. And it's not unusual for me to do a FaceTime call with Kevin, with my patient in the chair, and we can do a try-in whatever it is, and I'll be like, Kevin, here's a patient, here's Mrs. Smith, this is what you've sent me, what are your thoughts? This is what I'm thinking, what are your thoughts in terms of do we need to change toothpaste, etc., etc. FaceTime.
Yeah, and these are amazing. These are amazing little bits of information, certainly for the technicians. What works really well is that sometimes you'll take a photograph. A photograph's a bit two-dimensional. What you do is you'll put the prosthesis in the mouth. You'll have the patient talking, so we can have a look at phonetics. We can have a look at the incisal level, the lip line. You get so much more information from a video than you would do a photograph. So that makes my job a lot easier.
Okay, great. Guys, just to tell you, I'm looking at the phone here. I'm on Instagram Live with Kevin. If you're on Facebook and you want to see Kevin and me chatting, the best to move across, if you can, to Instagram, and you can see Kevin and myself doing an Instagram Live chat. If you have any questions, please drop us them. Kevin is a really, really well-experienced CDT. He does all my full arch prosthetic work for me. And if you have any questions, drop us a call. We've just covered stage 1. Stage 1 is the information I give Kevin and what he needs from me for me to then do my surgery. Stage 2, let's talk about the interim prosthesis, the all acrylic interim prosthesis, and potential complications. Now, I can tell you, I am really strict with my planning and getting that 15 millimeters of alveoplasty spot on. I'm meticulous about it. It's the way I've been trained. I was drummed into me, 15 millimeters, 15 mils. And when we're referring to the 15 millimeters, we're talking about restorative space, and restorative space for an FP3, planning for a metal bar and acrylic wrap prosthesis. Okay? So, Kevin, some of the common things that I've heard about, thankfully it rarely happens in our cases: chips, teeth veneering off, fracturing off. I've also heard people saying that the distal cantilevers on their interim prosthesis have fractured off. So, from my and one other potential risk is if the whole thing fractures, which would be an absolute disaster, especially during the osseointegration phase. Now, for me, the way I look at it, if I have bulk acrylic, get strength from bulk, then that's why I don't have it, because I'm so anal that I've got the bulk of acrylic for strength. In my interim prosthesis, I never ever have a distal cantilever. I've always sort of coached the patient and told them that they're only going to have maybe 5 to 5 at most. That's it. 10 teeth. I'm not giving them a distal cantilever. Now, yeah, I'm a big proponent of putting short implants at the back or pterygoids and having maximizing AP spread. But let's just stick to 4 implants. And so I'm a big fan of no distal cantilever in your interim prosthesis. But how would you recommend we manage if we get a tooth chipping or a tooth veneering off on our interim prosthesis?
Well, I think it's important what you were saying about getting that 15 millimeters drummed into you. If you're speaking to your technician from the very beginning and we're providing you something that's 15 millimeters and the communication is there from the very beginning, touch wood, hopefully we don't see many fractures. If you do get any fractures from your interim prosthesis, it's mainly chips of teeth. You can have a tooth debonding from the interim prosthesis, which is pretty simple to repair, really. You would just roughen up the socket, you would inject some chairside acrylic into there, pop the tooth back on. But like I say, if there's anything that fractures, then we want to know why. And I think good information to the patient when you've fitted the interim prosthesis, fingers crossed we shouldn't have any fractures. Yeah.
And I can, because I've given you all the correct information at appointment 2 or 3 before we've done the surgery, and you've given me a prosthesis that's thick.
Exactly.
And I know we've talked about it before, but the way that acrylic comes up and supports the teeth, the acrylic teeth, you know, we're maximising all our abilities to give that prosthesis strength. And so I think it's important to remember, in the interim prosthesis, that's all acrylic, the strength is in bulk. Yeah? So the strength is in bulk, and we've counselled the patient, yeah, you know, Mrs. Smith, this is bulky. You know, it's going to be bulky. This is the interim prosthesis. Please don't worry. The final will be smoother, will be thinner, etc., etc. And another thing, from a psychological point of view, I think it's important. You don't want to make too good a temporary, because when they get to the final, they'll be like, well, actually, the temporary was better. I don't know how. I mean, that's my sort of a thought in that department as well. So yeah, thickness really important. So it's kind of chips, veneering. Also, the other thing I wanted to mention in terms of occlusion, you know, it's important in the interim prosthesis that we're aware that we equally distribute forces across the whole prosthesis and all the implants, and also to think if something breaks, chips, wears, why did that happen? You know, is the patient following the strict instructions that we gave them? So for my full arch patients, they're on a strict non-chew diet for 3 months. And if something happens, ask them, well, what were you doing when that happened? So I think that's really important. Okay, so guys, because there's people joining in and out, etc., I just want to say a few things. Number one, I sent out some emails with the first 2 chapters of the ebook that I'm constructing. If you drop me an email and you want the first 2 chapters, I'm happy to send them out. They're covering 5 keys to treatment planning and looking at graft versus graftless in full arch. Also, I've had a lot of people contact me about planning full arch cases on a CBCT. Difficult for me to do that through Instagram and Facebook. So I'm doing a Zoom call next week, next Thursday, 8 o'clock, and I will post the link to that after this live session ends. So please look out for that. Also, I'm on Instagram and Facebook Live. Kevin is here with me. I'm very, very grateful for him to be here. Right, Kevin, final topic, and then there's some questions, so we'll go through them. Guys, any questions, please ask me in terms of surgical or about the full arch. But we've also got a highly skilled clinical technician to answer any other questions. Okay, so 3 sort of issues with the final, Kevin. So the main, I suppose, is sort of fractures, chips, wears. Again, I think going back to the treatment planning and again highlighting the importance of being aware of that magic number of 15 millimeters, I thankfully see very little because, you know, we've got adequate thickness. And I suppose the other thing to mention is, you know, we go into real depth when we plan our bars. You know, don't we? You know.
Yeah, and I think this is key. You know, from the very beginning. You know, the communicating side of things and giving me the right details, you know, we're very lucky to have, you know, minimal issues. And I think that is just purely down to planning. Me knowing what you want, you knowing what I want. And I think it's a really important relationship, and it's good practice to be on the phone to the surgeons, you know, what do you want from it, you know. What are the alveoplasty details? You know, what's the bigger picture? You know, what's the final plan? And I think we do that pretty well, don't we? We communicate right throughout, yes. Which, you know, gives us a good result.
Yeah, absolutely. And you know, Kevin, when it comes to, you know, the stage where we go on and design the bar, you know what I'm like? I says, Kevin, don't you give that green light. I want to see that bar. And you send me the files.
Yeah, it's good for both of us to see and both of us to question things, and this is what I'm saying about communication. It's good that it goes past both of us, and we both know what the end result's going to be. But yeah, we are very strict on our bar design, and we're very particular on how we want it.
Yeah. So if we go to bar design, you know, we know that for a FP3 bar, we're looking for a minimum of 3x3. And ideally, we go for 4x4. That's correct.
Yeah, we go for 4x4,
Now, it's important to remember, as clinicians, we need to be aware of that aspect. And because if your bar is too thick, all it does is eat into critical space that's required for the acrylic. And remember that acrylic gets strength from its bulk. So if you have a bar, say by 6 by 6, whatever, something, and it doesn't need to be that thick, all it's doing is eating into vital space that's required for the acrylic. And all that will happen over time is that acrylic will fracture and veneer off. So it's important that you're aware of what is the dimension of the bar and and why is it that way. Obviously, the bar needs to be a certain dimension for gone off. Yeah, some of these companies won't mill a bar unless it's 3 by 3. Am I correct, Kevin? I think the minimum. Yeah. So it has to be 3 by 3. But if we've got space, then we'll be looking for 4 by 4. Also, another important thing. Again, if you've got any type of a distal cantilever on your bridge, please design that bridge, that metal bar, that it extends beyond the last implant. That's really important because you don't want any unsupported acrylic. So I've seen many bridges and the acrylic just snaps off, and what's happened is the bar hasn't been designed correctly, and it doesn't have a distal distal cantilever off the last implant, and you need that for the acrylic support. Would you agree?
I think the key here is maintaining that restorative space, isn't it? That's vital from the very beginning. We need that 15 millimeters. Anything less than that, we run into, you can run into slight issues. So I think just planning it from the very beginning and making sure that, our dimensions are correct is very important.
Okay, so, I mean, from my experience, that's the number one complication with these hybrid bridges. It's sort of fractures, etc., and it's often due to restorative space. The second one is screw loosening. Now, that it can happen and is most often due to a lack of passivity of the metal framework. So screw loosening. So, I mean, there's a lot to go in when we talk about passivity, etc. And I'm not going to go into that here, but screw loosening is the second most common problem, and that is often due to a passivity issue. So please be aware, and you need to take appropriate steps in your construction of your prosthesis to minimize any misfit of the metal bar. Also, I would add, every year these patients are coming in for maintenance, and it's important to check that the screws are all adequately an adequate torque value. So check for any slight screw loosening. So I would check that on an annual basis. And then going forward, other sort of problems, you can lose some of the filling material out of the access holes. That's not a big deal. And another thing I suppose it's important to remember, it is an acrylic prosthesis on a metal bar. There will be a degree of wear, and often I'm saying to patients, you're going to be looking at a revision procedure at 5 to 7 years, where we're going to take this bar, we're going to take the prosthesis off, send it back to Kevin, he's going to refashion it, and in the interim period, we're going to give you something else. So it's not a big deal. And I've told them that they should expect that at 5 to 7 years. Would you agree? When we talk about it with dentures, you sort of new dentures every 5 years. I would expect to be revising the acrylic work at 5 years.
Yeah, definitely. Between 5 and 7 years, it's definitely a good revision. I think basically what happens over the years when they've been wearing these prostheses, certainly with the implants underneath, they may wear a little bit quicker than normal dentures because of the force that's applied to them. But like I say, with a good sort of revision process in place, then we assess it as we go along.
Okay. Do you want to just say a little bit about, I know we always, again, something else that I've been taught to be absolutely anal on, the intaglio surface of the prosthesis. Do you want to say a little bit about that, Kevin? Why it's so important? and why I always go on about it?
It has to be a convex surface, basically, to just apply a little bit of pressure there. Got to be able to get a TP brush in there as well. You probably know a little bit more about this regarding the hygiene of bridges. But yeah, we definitely don't want a ridge lap prosthesis. That creates all kinds of problems with stuff getting stuck inside it. So it's really important that you have that sort of round fitting surface.
Okay, perfect, amazing. Okay, guys, I think me and Kevin have covered everything that we wanted to. I'm going to just go through questions. If you have any questions, please fire them in. I'd love to be able to answer the questions very much related to the sort of planning the interim prosthesis of an FP3, which is all acrylic, and the final hybrid bridge. If you have any questions, please pop them through. What I want to say is that this will be uploaded to my YouTube channel afterwards, so you can catch up with it then as well. Also, I want to say next Thursday I'm doing a Zoom call where I'm going to talk through how to plan your full arch case on a CBCT. Afterwards, it's about an hour and a half. You'll know the A to Z of how to plan your full arch. So I will put up a link after this live chat on how you can sign up to that Zoom call next Thursday evening, 8 o'clock. I did have some questions. Yeah, here they are. Okay, on my Instagram, great. People waving, great. Okay, good. I have, just bear with me, guys, just going through these questions. Okay, what is the manufacturing process for the acrylic interim? That's Sarah. Normal denture processing or printing or milled? Kevin, that's for you. What is the manufacturing process for the acrylic interim?
The manufacturing process is we use a high impact acrylic. So it's pretty much the same as you would do a conventional denture. It's processed in a what's called an Ivercat machine. So we wouldn't mill them. We would just use conventional methods.
That's that injection molded.
Yeah.
Okay. Someone's asking me about post-op instructions for all on four. Yeah. So yes, for post-op full arch bridges, I can probably do a separate one on that. Really, really important. We're giving them instructions on hygiene, either TP brushes, there's stuff called X-Floss, Super Floss, yes, water pick, whatever it is, and we're assessing it. So really, really important to maintain the hygiene for long-term health of the prosthesis. What is a 4x4 or 6x6? Chetan, or a 3. That's the dimensions of the metal bar. So the metal bar for the final needs to be a certain thickness, so height and width for strength, and the minimum for these bars, either titanium or cobalt chrome, is 3x3. But ideally we aim for 4x4, so in thickness for strength, 4x4. So 4mm by 4mm or 3mm by 3mm. I hope that answers the question. Any other questions, anybody? Great, I've got a lot of people, kind comments, thank you, really appreciate it. So just lastly again, Zoom call next Thursday, I'll put up the link, talking you through the A to Z, how to plan your full arch case on a CBCT. It's difficult for me to do on Facebook and Instagram, so I'm going to do a Zoom call. So if you'd like to sign up to that, please click on the link, and I will be asking you for your email address. Also, want to just say thanks for everybody and all the feedback for the PDFs that I've emailed out for the first 2 Facebook Lives, 5 keys to full arch treatment planning and graft versus graftless. If you'd like to join the mailing list to get those 2 PDFs and the future PDFs that are in construction, then please leave your email address on the comments or PM me your email address. Okay, Kevin, any last words? Anything you want to say? No.
Sorry.
I said any last words? Anything you want to say?
Yeah, just if you're going to be doing these sort of bridges, these SP3 bridges, let's communicate with your technicians, give them all the information they need, have a good relationship with your technician, speak to them, find out what their plan is, tell them your plan, just so we're both singing from the same hymn sheet, gives you good results.
Yeah, and I absolutely echo that. Because firstly, I see Kevin as a friend. Secondly, as a work colleague, and we communicate 3-4 times a week. My lab slips aren't great. I just say, call me Kevin, and I would say that it'd be correct that we speak about every case I send you, regardless if it's
every single case at every single stage.
Yeah. So, and it's a direct phone call every single case.
Yeah.
Because we want to do the absolute best for our patients. So, I really appreciate everyone's comments. Everyone, thank you for tuning in. I hope that's helped. So we've covered stage 1, what information I give my technician and what the technician needs from me to plan a full arch case. Second, common issues potentially with an interim prosthesis and how to minimise them. 3, common issues and how to avoid them when it comes to a full arch hybrid final prosthesis. Thank you, everybody. Have a lovely evening and stay safe. Big thank you, Kevin. We've got a question, a wee cheeky last question. Let's see, Bilal. Okay, do you ever skip the temporary prosthesis if the patient is already edentulous and go to the final once implants have osseointegrated? Also, please could you... Okay. Do you ever skip the temporary patients? No, we don't. I don't skip stages. Usually, the plan is to immediately load. So I'll immediately load with an interim prosthesis. I suppose one of the real benefits of, there's loads of benefits with immediate loading, but the benefit of giving the patient an interim prosthesis, it allows them to get used to something that's fixed in their mouth. They can then get used to that, get used to the aesthetics, the feel. You can then get feedback when you come to make your final prosthesis, what their thoughts are regarding the tooth position, etc., etc. So no, we always like to go to an interim prosthesis fixed and then a definitive, unless obviously I wasn't able to immediately load, and then I would go to the final, obviously, and they'd get a denture in the interim. So I always like to immediately load if I can. It's the surgery's cleaner, less stages, it's cost effective, and it makes the whole construction of the final prosthesis so much easier if we can give them.
I suppose we've always got a spare as well, haven't we? Then. Yeah,
absolutely. Yeah, well, excellent point. Thanks, Kevin. Yeah, another real benefit of having an interim prosthesis, if there's ever an issue with the final or the definitive, even if it's a chip or it needs a revision, you can take it off and you've got something that can go in that's fixed straight away. Yeah, excellent point. So it's always good to have a spare, in essence. Great. Super. Thanks, everybody. Have a great night and stay safe, and we'll catch up with you next week for more. See you later. Thanks, Kevin.